Good morning again, everybody. I'm sorry to push you, but we are eating into the time of the next session, and we have to finish at 12 because of the lunchbox sessions. The next session switches tack a little bit about timing of surgery, and it's a pleasure to introduce Ben Bridgewater, Professor Bridgewater, to open up the session talking about asymptomatic patients. Ben, I think, is known to all of you. Thank you, Ben.
Thanks very much. Apologies for being late this morning. It's a bad show when you organise a programme and then get here late, but I apologise for that. Really, just to get things open, I just want to do a bit of a straw poll. So this character here, fit 78-year-old guy, found to have a murmur. He's genuinely fit, plays golf, rushes around the golf course. He's had an echo. He's got... that's a very severe MR, prolapse P2, normal left ventricular function, normal left ventricular size, and no other significant findings. Can I just do a straw poll of the surgeons in the room? Who would suggest he has a mitral valve repair, and who would suggest he got in a watchful waiting group? So we go surgery first. Who would recommend surgery for him? Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, so quite a few. Who would recommend watchful waiting in that sort of patient? Okay, what would you like to know? NC-style bone, normal.
No, but I think that's what I mean. I need to know. Normal would be less than 45 in Europe and less than 40 in the United States. I need to know the number.
Not whether it's not what. Okay, yeah, okay.
I think Dave's right. I think what does asymptomatic means? I think a lot of people at this age who say they're asymptomatic, you put them on a treadmill or exercise.
Exactly.
Get very symptomatic. The only thing we would do is measure his BNP.
You're an exercise study.
Okay, fair enough. So what I want to do at the end is come back to this patient and see if anybody's changed a view across the things you're going to hear over the next hour or so. But what I did want to show you is what the current outcomes for this kind of guy is at the moment. So I don't know if you've all seen the SCTS iData app, but it's downloadable on your phone, so you can actually put in those sort of criteria, find out how many patients fulfill those criteria and actually what their outcomes are. So if you put this kind of guy in, we don't have the sophisticated measurements which we've heard about, but we get some rough data from that. So there was about 220 of these people over the last 4 years with a mortality of just under 1%, 1 year mortality of 4.5%. So that's their operative mortality. So my point here is there are some tools to help guide some of the decision-making process and help feed into the sort of risk-benefit discussion. So that's really all I want to say, and now I want to hear more from the other speakers about how you base your decisions in those types of patients. Thank you very much.
Ben, thank you very much. Mr. Ahmed from Brighton is going to talk to us about the argument for early intervention.
Thank you for inviting me to talk today. So I'm talking about the case for early intervention in severe mitral regurgitation. I'm limiting the talk to the degenerative MR, where there's a primary valve problem and not functional disease. Now, I'll just quickly run through you my approach in clinic. I assess the severity of the regurgitation with echo, see if the patients are symptomatic, look at if the symptoms are related to the valve disease, and what is the patient's life expectancy. We talk about risks and benefits of surgery versus a natural history. What does the patient want, and can I offer a repair that will be durable? And that's really based on my knowledge of the AHA guidelines and the European guidelines, which are slightly different on a couple of different aspects. Now, if we look at the indications for surgery for mitral regurgitation, they both agree that if you've got symptoms and you've got severe MR, that's a class 1 indication. But in asymptomatic patients, there's a number of trigger points. And as we just heard, the trigger point for LV systolic dimension is slightly different in both of these guidelines. However, what I want to try and show you in the next 6 or 7 minutes is how I think these guidelines should evolve and how they might evolve. I want to demonstrate this to you by looking at the natural history of severe mitral regurgitation in the asymptomatic patient, and look at actually what happens if we stick to those triggers for surgery that are recommended in those guidelines and the outcomes we get if we operate after those triggers have become apparent. So looking at the AHA guideline, if we look at severe mitral regurgitation in an asymptomatic individual with a normal LV, the AHA guideline recommends that it's reasonable in experienced surgical centres to offer surgery if the rate of successful repair is more than 90%. It's a Class 2A indication. The European guidelines have a 2B indication for this, and actually are a little bit more conservative and ask for two other parameters to be reached, which is either left atrial volume or exercise pulmonary hypertension. I think we want a common goal, effectively, no matter which way you sit on the fence in this, and we want a patient outcome where they survive, have good quality of life, LV function is preserved, and the valve is repaired. So let's look at the natural history data. Here are four of the main studies that I've found in the literature, and you'll see that the mortality rate per year in a patient with severe mitral regurgitation who is asymptomatic varies between 0% and 8%. Interestingly, the ones where there is a lower mortality rate per year, these are concentrated on the younger group of patients. And also, some of the data that's available, the lowest mortality is associated with groups where the investigator is actually following the patient up themselves. Now, if you plug all that data onto the same curve, you can see that within 5 years, 40% of patients in this group actually reach criteria from the guidelines that I've talked about to trigger indications for mitral valve surgery. This is corroborated by data from Enrique Serrano, where they actually looked at the effective regurgitation orifice. And you can see that the worse the MR, the worse their survival is if you continue to watch and wait. Now, mitral regurgitation is not as bad as, for example, aortic stenosis, which has a definite sudden death rate per year. However, if you actually look at the data, even those in NYHA1 and NYHA2 class have a 1 to 3% sudden death rate per year if you are dealing with a flail leaflet. It is not an indolent disease. Okay, I just want to talk of the triggers now. I want to look at what happens when a trigger is reached and the impact of that after you've operated on somebody once you've reached one of those triggers. If we look at the left-hand slide, this is looking at NYHA status, so NYHA 1 to 2 at the top and NYHA 3 to 4 at the bottom. You see that the long-term outcome, once a patient has reached NYHA 3, is approximately 30% different in terms of survival at 10 years. This is worse once the ventricular function starts to deteriorate. If you look at the second line here, this is basically looking at what happens when the LV function goes less than 60% as associated with the guidelines. If you wait for that to happen in these patients, the long-term outcome at 10 years is 20% different after surgery. Now, this data from David's group published last year. I can see that this difference is not just between 1, 2, and 3, 4. It's actually apparent after you reach NYHA 1, and there's a difference at 20 years in terms of outcome between NYHA 1 and NYHA 2. Now, I think it's difficult in these patients who are elderly, already deconditioned, possibly overweight, unfit, to actually start differentiating between NYHA 1 and 2 in clinic and actually trying to work out, if you are watching them, when do they actually reach the NYHA 1 status if you're reviewing them once a year? Now let's look at the triggers. Once you reach atrial fibrillation, 10-year outcome after mitral valve surgery is 14% worse. And with pulmonary hypertension, the gap widens even after 3 years. Now we know that mitral valve repair is a better option in terms of mortality, longevity, maintaining LV function, and avoiding prosthetic-related complications. Repair is on the increase in America. In the UK, this is straight off the STS database. Replacement rates are going down. And mortality, there was a blip in most recent figures in the UK, but mortality runs between 1 and 1.5% most of the time in the last 7 or 8 years. And the international data is even better for this in experienced centers. Now, there's a low rate of complication after repair, even at 20 years, and the reoperation rate is also very low. In recent years, patients have the opportunity to have minimal access techniques, therefore allowing them a quicker recovery after mitral valve surgery. And in addition, there is data to show that the cardiologists are not even sticking to the current guidelines, and therefore we are losing patients. And I'm sure you've all seen patients attending your clinics with severe MR whose LVs have already started to dilate, which already puts you on the back foot in terms of getting your outcomes appropriate for these patients. So I think we need to look carefully at the patients. We do need to catch them early. You need a cardiologist that refers them very early to get the best outcomes. As I've shown, every time you reach one of those triggers that are associated with the guidelines, your outcomes are automatically going to be worse at 20 years. And I think we need to look at the surgeons operating on these patients and offer them at least a 90% chance of repair, and maybe even look at the minimal access route, and that's an interesting point for discussion. So I think this dilemma can only really be settled with a proper randomized controlled trial. However, I hope I've shown you that the weight of evidence at present, I believe, firmly lies in favour of surgery. There are other triggers that are coming onto the agenda, like BNP and left atrial volume. Thank you.
Can I ask just a quick question on that? So the interesting thing in this bit for me is this experience centres thing. And we know that in the UK, the volumes by centre are relatively small compared to what we see, at some other places internationally. So there is only one centre, I think, who consistently does more than 100 isolated mitral valve repairs a year. And many centres do sort of less than 40, some do less than 20. We also know there's a significant proportion of people who actually end up having mitral valve replacements for relatively non-progressed disease. And 60% of people with degenerative valve disease get repairs, which means more than 30% of people get replacements. How can you ratify that kind of data with the kind of number of hands that we got up here, which suggests this guy should have a mitral valve repair at an early stage when we know that those outcomes may not be as good as they could be in the long term because of those risks?
Are you asking me, Ben? I'm
asking you, yeah. You're there, you're arguing the point, so I'm asking you, yeah.
I think you've got to look at quality from individual surgeons, and I agree, in the UK there is a huge variation if you look at centres. But I remember you talking yourself at last year's society meeting, and that data that was presented from the STS, I think it was either Bolling or Gami that presented that in the Annals of Thoracic Surgery, that looked at those big differences between centres. But if I remember rightly, the data that you looked at from the UK did not show that discrepancy from centre to centre, but there was some difference amongst surgeons. So I think it's very surgeon-specific.
No, the data, I think, shows a huge variation by centre, and there will be an even greater variation by individual surgeon. I guess that's my concern, really.
Okay.
I'm sure we'll get further into this as we go on.
And I think that's a very valid point.
Well, I'll just throw it in now. You're arguing for specialist centres, which I've been arguing for 10 years or more, and I think it's absolutely right. So let's stir it up a bit. And I think these should be surgeons doing more than 50 a year to be doing this.
Can I?
Neil, please, join in.
Very good review of the literature. The problem I have is with the literature. If you look at the numbers of those series, they're tiny. And if you look at your Kaplan-Meiers looking at survival at 10 years, the number at risk is about 10 patients. So I'm not sure we really know the answer here. I'm not sure we really know what the outcomes here. I think most of us who do this surgery kind of believe in what you're saying, but I'm really not sure we have much evidence upon which to base that. And I think it's like guidelines. This is not my quote, but I kind of liked it. They're a bit like sausages. They're quite interesting, but if you saw how they were made, that you would never use them.
We're going to have to move on. But can I just throw in something here? Retrospective data of this kind is very difficult to know how to handle. If you sent all your cases to Professor Adams, for example, you're going to get one result. And to you as well, Neil. If you send it to many others who are doing a few, you're going to get a very different result. And a lot of what's in the literature is a mixture of all of these. So prospective data based on state-of-the-art surgery is what we really need. And then we can start deciding about the patients that Ben mentioned at the beginning. And how we get there is very, very difficult. And If you want to buy, you know, a very good piece of furniture, you go to a high-end furniture shop. If you go to you know, the old Woolworths, you'll get what you pay for. And I'm afraid it's the same for surgeons. We have a huge variety of abilities amongst the surgeons. And we've got to have specialist centres delivering specialist audited work, I believe. We're going to pick this up later on. Should we move on to the next speaker and get a different perspective? It's my great pleasure to introduce Dr. Rosenhek, one of the few cardiologists in the audience. Thank you for coming into the Lion's Den. We look forward to hearing what you have to say.
Thank you. It's a big pleasure to speak in this audience of majoritarily surgeons, and I will give the argument for watchful waiting. Obviously, you have seen already these slides, and these are the data that actually define the indications that were currently used, and I agree, these are small studies. Most of them are studies that look at preoperative characteristics of patients undergoing surgery and then look at the long-term outcome. And what you see is that if patients have severe symptoms at the moment of surgery, they have a poor outcome. And this means you have to operate on them at the onset of symptoms. And this also is the point when we're talking about watchful waiting. It is still an aggressive strategy. We have triggers in terms of left ventricular ejection fraction that have been defined at the Mayo Clinic, and you can see if a patient is operated with an ejection fraction below 60%, his long-term survival will be less good as if he's operated with a preserved ejection fraction. You also will see that the majority of the patients included in this study were already severely symptomatic, and only 10% were asymptomatic. So we do not know if these data truly can be extrapolated to truly asymptomatic patients. And indeed, it seems that even among patients with a reduced ejection fraction, symptoms are the most important predictor of long-term survival after surgery. In terms of atrial fibrillation, indeed it is true that if patients have atrial fibrillation at the moment of surgery, their long-term survival will be impaired as compared to patients being operated in sinus rhythm. I think the data from the STS database shows smaller difference in survival at the long term as compared to the data that we have seen. We have data favoring the operation in patients who develop pulmonary hypertension, and indeed those patients who have a pulmonary arterial pressure above 50 millimeters of mercury will have a worse survival in the long term after surgery. However, again, 37% of the patients in this study were being operated in the New York Heart Association class 3 and 4. This means that we cannot be sure that the same picture is true for truly asymptomatic patients being operated because of pulmonary hypertension. And finally, this is an interesting study from the MEDA trial that has included patients with severe mitral regurgitation because of a flayed leaflet. And what these authors shows, and I think this is the point that David wanted to make, is that if the end-systolic diameter is larger than 40 millimeters, there will be an impact on survival after surgery, as reflected in the Kaplan-Meier curves. On the other hand, as long as the end-systolic diameter is below 40 millimeters and these patients are being managed conservatively, there is no excess of risk. It's once that the end-systolic diameter is above 40 millimeters that we're seeing an excessive risk of mortality. And now we're coming to the truly asymptomatic patient. The debate has been triggered a while ago. Probably this was the first paper that triggered this debate. It was a paper published from the Mayo Clinic looking at the sudden death rate in patients with severe mitral regurgitation and flayed leaflets. And these authors have described 25 cases of sudden death during a follow-up period of 4 years. But if you look into the details, patients with severe symptoms indeed have a sudden death rate of approximately 8% per year. On the other hand, those patients who have a preserved ejection fraction and who are asymptomatic or minimally symptomatic in New York Heart Association class 1 or 2 have a sudden death rate of 0.8% per year, which in itself is probably not a sufficient argument for early elective surgery in all of these patients. You've also seen this paper from Maurice Enrique Serrano where mitral regurgitation was quantified using the effective regurgitant orifice area. And these are patients that were initially managed conservatively with severe mitral regurgitation, and they were initially asymptomatic. And what you see is a mortality close to 40% within 5 years for patients with severe mitral regurgitation, and close to 30% for patients with moderate mitral regurgitation. So even these patients fare poorly. But these patients did not have a regular follow-up exam, and this is something that we need to stress on. If following patients, we need to see them closely, and patients with an ejection fraction between 50 and 60% were included in that trial. Obviously, there's a temptation of surgery, especially if I tell you that surgical risk is close to 0% and repair rate is close to 100%. And if these factors are indeed verified, I think we should go for surgery. But is this the truth? And in valve disease, sometimes there is a debate between complexity and universality. I just like this. This was a small conversation that Einstein had with Charles Chaplin. And Einstein said, what I admire the most in your art is its universality. You do not say a word, and nevertheless the entire world understands you. And Chaplin replies, that is true, but your glory is far bigger. The entire world admires you, although no one understands you. And I think we need to understand what we're talking about. And if I just showed you these are data from a South Korean paper, comparing an early surgery approach with a waiting for symptoms approach in patients with severe asymptomatic mitral regurgitation. If you look at this line of the early surgery group, these patients tend to live forever. This seems to be one of the ways to achieve eternal life. But I think maybe even without having a mitral valve problem, we should have mitral valve surgery to live longer. But we need to look at the details. It was a registry, which is different from a prospective randomized trial, and this is why such trials are so important. There's no surgical mortality in either of the two groups, and patients being lost to follow-up, 17 of these, apparently all in the surgical group, so we do not know if they're indeed all alive at the end of follow-up. There were 3 unaccounted deaths. They were considered as being non-cardiac because they were considered as being stroke or infection, and thus we cannot, on the other hand, be sure that they are unrelated to the mitral valve procedure. And then there were 22 triggers for surgery in the initially conventionally managed patients, namely heart failure is a trigger for surgery, and these patients were operated. There were 5 patients who died of congestive heart failure, but they had refused surgery, and there was 1 sudden death in a patient who had developed symptoms. So I think there is no conclusive answer in the end from that study if we look into the details. And I want to highlight this paper from the MEDA trial, which actually is a paper that supports early aggressive surgery. But I think, again, we need to look at the details. It was very prominently published in the Journal of the American Medical Association last year. And you see the early surgical group seems to fare significantly better than patients with a initial medical management in the long-term outcome. So what is the MEDA trial? The MEDA trial includes only patients with flail leaflets. They were recruited in 6 centers over a time span of 24 years, and there were 1,021 patients without a class 1 indication for surgery. So this is the image. If you see this, you want to go for surgery. But again, I strongly suggest that we should go into the details. Again, it was a retrospective registry. And if we look at the propensity score matched cohort, the difference in survival becomes already significantly smaller. Furthermore, there were 19% of patients with a class 2 indication for surgery in the initial management group. And I think this also can cause a bias in the interpretation of these results. And watchful waiting was defined as each patient had follow-up visits with a physician within each participating center or elsewhere. And this elsewhere means that there wasn't watchful waiting. They were just followed anywhere and however it was deemed necessary. And there was an arbitrary cutoff defining the 2 groups, namely early surgery was defined as within 3 months of diagnosis. And I want to show you this. These are data from time of diagnosis of severe aortic stenosis and surgery in Canada. These are all patients in British Columbia. And you can see that even from booking to surgery, there's a median delay of 70 to 100 days. And the delay from primary care physician to surgery is, on average, in the range of 230 to 280 days. So what does it mean to have a delay of surgery of 90 days? If you have a waiting list of 3 months, you're already in the watchful waiting group. So this is a strong limitation. Let's do the math of this META trial. 6 centers included patients over a time period of 24 years. They included consecutive patients. So they had 1,000 patients without a class 1 indication. That makes 7 patients per center per year. And there were 446 patients being operated early. That means 3 patients per center per year. So in other words, 1 patient per center having early surgery every 4 months. So either there's a problem with the data, or the problem of seeing these asymptomatic patients is not a problem because it is very, very rare. And indeed, let's do the math and go again to the publications. The META registry has been very productive. There are 6 papers out since the conception of this registry. First, they started with 4 French centers, then the Mayo Clinic joined, and you see they're publishing with 5 centers. And the last paper, which was the JAMA paper, added data from a small center in Belgium, from Louvain. And you can see that at least 3 papers, the 2nd, the 5th, and the 6th, included consecutive patients over the same time span from 1980 to 2004. But look at the number of patients, 739, 862 for the same centers, and then you add a small center, and you end up with 2,097 patients. Are these really consecutive patients? Should we base our decision on such data? I'm not sure. And even Mayo Clinic data confirm that if patients are operated because of severe mitral regurgitation, and even though 60% of these patients had advanced symptoms, life expectancy can be restored for different age groups if you achieve a successful mitral valve repair. So the data are not that conclusive, even if you look at data from the same centers. And these are the most recent American guidelines that were just published last week on March 3rd. And you can see that now there's a 2A indication for truly asymptomatic patients. I think we do not debate that patients should be operated when they have symptoms, when they have a depressed ejection fraction, an end systolic diameter above 40 millimeters. The European guidance differentiate between patients with a flail or a non-flail 40-45. I think we can go for 40 millimeters. But the American guidelines say now that mitral valve repair is reasonable in asymptomatic patients with a normal-sized ventricle with a preserved ejection fraction, when the likelihood of successful and durable repair without residual mitral regurgitation is more than 95%, with an expected mortality rate of less than 1% when performed at a heart valve center of excellence. This is a class 2A indication. I do not have a problem with this indication, but what we really want to achieve, as Carpentier's concept has shown, want to preserve or restore full leaflet motion, create a large surface of coaptation, remodel and stabilize the entire annulus. And as Carpentier said, the duty of any valve surgeon today is no longer to correct a mitral valve regurgitation, but to correct a mitral valve regurgitation for the rest of the patient's life. And these are the data. Currently, from the STS data, there was an improvement, but repair rates are insufficient. In 2007, 30% of patients that were included in that registry ended up with a mitral valve prosthesis. There is a risk of reoperation for valve failure in the range of 1% per year. If the surgery is performed in good centers, these are data from the Cleveland Clinic. And I very much like this paper, and particularly the title. And there are several of the authors present in this room, namely the lottery of mitral valve surgery. And you clearly see that the percentage of mitral valve repair, these are UK data, is increasing with increasing numbers of operations. These are UK data. But you can still find centers that do large numbers of surgeries with insufficient numbers of mitral valve repair. But if we give out a general recommendation for early surgery, we give out a recommendation to work with the system. So there are some patients being operated in these centers with suboptimal results. And probably what matters most is surgeon experience. And if surgeons have a large experience, their repair rates are substantially higher. These are data from the STS database. But again, the current ACC-AHA guidelines recommend a repair rate of 95%. You see, you can draw the line here. Probably there's some variability, but there are probably very few surgeons that will achieve a repair rate of 95%. And we want to have a low mortality at the same time. We want to have a mortality below 1%. And these are, again, data from the STS database. And if we look at the operative mortality, it will be in the range of 1% for high-volume centers performing more than 140 procedures. It may be substantially higher for low-volume centers. Or mid-volume centers, it will be in the range of 2 to 3%. And we shouldn't forget that there's major morbidity and mortality involved even for patients being operated in a high-volume center. So if we put down the recommendation, the current recommendation from the ACC-AHA having a low operative mortality, this says that we should only operate on these patients in high-volume centers, which makes sense. But then again, we have to find the surgeon that will actually achieve a mitral valve repair with a success rate that is indeed above 95%. On the other hand, is it safe to wait for the other criteria for surgery that are currently in the guidelines? And this is a strategy that we have tested in our practice, where we followed patients with asymptomatic severe mitral regurgitation on a 6-monthly basis, and we referred them to surgery at the onset of symptoms or if other echocardiographic criteria for surgery were reached. And the overall outcome of such a strategy was good in terms of overall mortality, even in patients with flail leaflet. But the indications for surgery occur at any time. So indeed, if you do not operate on these patients, it implies that you need to follow these patients closely, probably at 6-monthly intervals, because you can see that events occur frequently, and 50% of these patients will require surgery within 8 years. On the other hand, the other 50% of the patients have a good quality of life for another 8 years, which is non-negligible. So to remind you, watchful waiting is an aggressive approach. It involves close clinical and echocardiographic follow-up. It also involves instructing the patient to promptly report symptoms and to refer patients to surgery at the onset of symptoms. And I agree, we know that half of the patients with a clear indication for mitral valve surgery are sometimes not referred to surgery in clinical practice, but this is a different problem. And probably having heart valve centers of excellence and also heart valve clinics to closely follow these patients and guide the decision-making is one way to look into the future. So to summarize, the overall goal is obviously to improve patient outcome. Asymptomatic patients can be followed safely until symptoms develop, or currently recommended cutoff values for left ventricular size or function, pulmonary hypertension, and atrial fibrillation are reached. But such a strategy requires careful follow-up with serial echocardiographic examinations. And on the other hand, mitral valve repair surgery leads to excellent results, but it should be performed in high-volume centers by experienced and dedicated surgeons. I thank you for your attention.
Just quickly, this business of asymptomatic, I don't know what everybody else in the audience finds, but quite a lot of patients that I operate on who say they're asymptomatic come back to the clinic saying they feel 10 years younger, and many other comments like that. So, and the other thing, most of us, when we go to the doctor, we're frightened to tell them the truth, and we play down what we have. So how do you really know they're asymptomatic? Do you exercise them? Do you do any other thing, or not? Do you just take their stories?
Well, the definition of symptoms is a subjective perception by the patient. So indeed, this is the definition. There are patients where we have problems believing them. I mean, they sometimes they restrict their daily functioning, their daily exercising. So if we have doubts, we recommend an exercise test. We do exercise testing to unmask latent symptoms. But in other cases, it is very clear that the patient has.
They should all have it?
Should they all have it? Probably
Well,
in the older
anybody's got
patients.
severe mitral
In the older
regurgitation, should you
patient,
not stress them?
well, in the older patient, it becomes unspecific. We know that from aortic stenosis data that patients above the age of 70, if they have a mild dyspnea during the exercise test, that may be non-specific. On the other hand, if you have the capacity to do an exercise test in every patient, you can do that. There is nothing to say against it. We use it on a clinical judgment for the individual patient.
Such important data. Yes, Hugo.
Ben alluded to the key notion in this matter, and the key notion is the hard valve center of excellence. Now, you've alluded to the piano player earlier on in the previous session. We all know that the Cleveland Symphonic Orchestra, the Berliner, and the Vienna Symphony, they are excellent orchestras. How come that surgeons pretend they can play the violin and the piano and the flute at the same high-class level? We have to create orchestras and there's more. We make cardiologists believe that that is the truth. How come you guys believe that? This is the way, actually, we encourage the vertical referral pattern, and the vertical referral pattern is critical in this matter. Patients should be sent to centers where there is a good violin player and a good flute player and a good piano player. And never ever you're going to have your coronary arteries operated on by me or by Alain Carpentier or by Tyrone David. No, you want to go to a guy who does coronary artery surgery every day. And the ego of the surgeon there is a terrible problem, I think. They think they can do everything.
The center-specific data is so dangerous that any surgeon can declare an interest and attract referrals. It means nothing. Audited data is the outcome, I think. The outcome is the important thing. We need to move on. Yeah. Can I just give you a present for braving the surgeons and also the booby trap on the step when you came to present? Thank you very much indeed for your presentation.
Well, it's a pleasure now to invite David Adams back onto the podium, and we'd like to hear what his incisive intellect is going to do to this debate. David.
So, I'm going to try and add some clarity and tell you that both of the first two speakers are correct. So we went over my disclosures, not much there. So really there are four things we have to, I think, address. There's a fifth one, but I'm going to save that for this afternoon's last session when we talk about sort of the current status of mitral valve surgery. But the four I think that are relevant for this asymptomatic session are, do we know the right triggers? Do we really know the risk of surgery? Something we've already been hearing about. Is a repair assured? I'm going to expound on that a little bit and talk about repairs being long-lasting. So let's first catch up just one more time on the guidelines. European guidelines first. At the first thing is, and I'm sorry I would have addressed this, I thought Raphael might get it, maybe we'll do it in discussion, is the quality of echo. You have to have severe MR. Moderate to severe, maybe severe, probably moderate, what grade 4+ or 3+. This is a major problem. If we think surgery is a scatter plot and we have a lot of work to do, the quality of echo is a super scatter plot and we have a lot to do. So that's one issue. The second thing is then we have the numbers, 60 and 45 in Europe, but it really should be 40. I think 60 and 40 is right. What's conspicuously absent from last year's guideline in Europe and the brand new guidelines that just are in e-print right now from the ACCHA as of about 5 days ago is the lack of exercise testing. I don't see it in the algorithm. Don't see left atrial size mentioned. And they really, again, hold hard to these fast trigger points, 45 or 40 and 60 as sort of absolute cutoffs. And I think this is all problematic, particularly as you start thinking about asymptomatic patients. So you guys saw this paper a few minutes ago from Raphael talking about watchful waiting. I like the point he made that not everybody develops surgery. On the other hand, one of the problems with watchful waiting is you do develop symptoms. Symptoms are a trigger for surgery. Then do you believe, is it okay to operate on people that have symptoms? I don't know. I'm not so sure. They don't die in the operating room, or the first 2 years or 3 years that they remember you or that you keep seeing them. But there is good data that looks 10 years later, mild symptoms, and we saw that before in the first talk, mild symptoms aren't good for you. They do have some implication. Again, because they're not randomized and these patients aren't really properly, addressed before they go into these small series, or in this case, a large series from Cleveland, minor symptoms probably aren't good as asymptomatic. So that's one issue that the guidelines don't talk about. How about ejection fraction? This number of 60s based on 25-year-old data that you guys have seen. This was a paper from Mayo talking about if you want your post-op ejection fraction to be greater than 60, your pre-op ejection fraction needs to be greater than 65. I don't know about you, but I like that number 60. You can say, well, but don't worry, if your ejection fraction is 49, you should live a good long life. I bet you live a longer life if it's 65. It's just a hunch. So again, these numbers as absolutes are a little problematic for me, especially considering the sort of historical nature of a lot of them. Now, this MIDA data series, as Raphael said, has a lot of issues, and if you read these papers carefully, you'll discover them, and he pointed out some of them. But they also are I think, at least thought-provoking, and this is one that I really referred to when Ben asked, should we operate on that patient? I don't know yet, because I think this is very provocative. That is, are you near a trigger point? Forget the triggers. If you're under 40, under 60, over 40, I think everybody, the answer, at least for your boards, for you young people, is you should operate. But then you have the asymptomatic patient. What they looked at now, look at these 3 bars. If your ejection fraction is less than 64 and your end-systolic dimension is greater than 37, then about 1/3 of those patients develop post-op LV dysfunction. And then it just goes down. If you have either or, less than 64, above 37, and then if you don't have either. So, or if you're outside of the trigger point for 64 and 37. So 60 and 40, you've got to remember, but I think as a clinician, we have to be a little bit more clever and realize that if you're near trigger points, I get much more interested in asymptomatic surgery than if you're far away from trigger points. I guess that's the point. Left atrial size, he says, is nowhere in any of the guidelines, but it's becoming important. Again, it's only one series. There's not that much confirmatory evidence, but I think there is a general sort of level of evidence C and 2B, or maybe it's 2B. I think it's heading toward 2A. There's a lot of talk in the bar that no one wants a left atrium over 55 or 60. Once your left atrium becomes gigantic, whether you're asymptomatic or not, probably that's something people should be thinking about. So let me show you the pathology here. You have P3 prolapse. You're gonna, by definition, severe MR, right? We know that has to be severe. That's gonna be repaired 95, 98% of the time everywhere, hopefully, with very low risk. And you ask about that question, Ben, and I'll say, what if the patient's 42? And you have an EF of 62 and systolic dimension 39, LA size of 53. How many people would operate? I'm going to operate. What if you're 82? Same thing. You're asymptomatic. You've got the lesion I showed you. Your EF 62, 39, and 53. How many people would operate? I'm going to operate. You're almost at the trigger points. You have multiple things that tell me the same thing, that your MR is getting close. Your life expectancy is 89.5, and if you want to exercise them to show that their event rate is going to be very high, you could, but I probably would. Now let's just change the story around a little bit. Now you have an ejection fraction of 70, end systolic dimension of 33, and a left atrial size of 42. How many people operate on a 42-year-old woman this time? I will too. Hugo raises his hand. I will too. I'm looking at 50, 40 years. I won't force her to surgery. I'll tell her, I'll show her. I have the whole little thing canned in my office. There's no emergency, 6-month interval follow-up. You're going to need this to live your normal life expectancy. Don't cancel a wedding. Graduate from school. If you're a teacher, wait till the summer. If you're a tax attorney, wait till April 15th in the United States. But sooner than later, when it's convenient with you or your work and your family, don't let doctors decide you should have surgery. How about the same patient and they're 82? You showed a 78-year-old. How about the 78-year-old golfer, EF 70, end systolic dimension 33, left atrial size 42? How many people are going to operate? Hugo, 1. So that's what I mean. We have to be doctors. We have to be a little bit clever. This patient is very early in the course of the disease that may never need intervention to improve his life expectancy or quality of life. Maybe exercise him, but chances are he's going to be okay. And then what if all those 2 examples I just showed you in 2 different age group and 2 different sexes, what if that's the valve? What if it's bileaflet Barlow's with calcified annulus? Everybody going to operate for the same 4 patients? Hugo raised his hand 4 straight times. I don't think I would. You take an 82-year-old woman with an end-systolic dimension of 33 and EF of 70 with that valve to the OR? I sure wouldn't. So this is what's missing. When you talk about Serrano's paper and you talk about Raphael's paper, this is a problem. They tell us there's regurgitation and we trust them there's degenerative disease. Is it holosystolic, older people, short histories? Is it Barlow's disease, longer histories, more preparation of the atrium, maybe less decline of ventricular function from acute volume overload because you had elongation before you had prolapse? We don't really know. None of these papers tell you that. And while I'm at it, we should never publish a paper in mitral valve disease that doesn't tell you the amount of total mitral surgery during the time point studied. 3/4 of the literature reports a series of valve repair and doesn't tell you how many replacements there were in that institution during that series. Therefore, that's a real selection bias. So that we should really try and do that. Now, Raphael points out that there's a hint of what I just told you about etiology. He showed it here. Look at the difference between prolapse and flail leaflet. I actually show this slide to patients too. If they have a broken string and they have holosystolic regurgitation, their chances are a little bit less for event-free survival. So I tell them that patient I might advise a little bit differently than when you have chordal elongation, mid-systolic leak, maybe you have multiple jets, but your baselines may not be severe. So I'm a little bit more conservative there. How about the risk of surgery? We've already talked about that, but I'll show it to you a different way. So here's a paper from my good friend Rakesh Suri in the Mayo Clinic. And they're basically, the paper, when you read it, it talks about if you just read the methods, it talks about 700 patients. So if you just quickly scan it, you think it's 700 patients. But when you get down to the methods part, actually it's 300 patients. So it's 301 mitral valve repairs over 3 years, 199 standard, 101 robotic approach for degenerative mitral valve repair. That's what you get. You don't get the replacements during the interval, you just get that data. Then you look at their postoperative outcomes. There are no deaths, 1 stroke. That's pretty good. 301 of anything with no deaths is pretty good in surgery. Then if you're really interested, you have to keep reading. So it really was 301 patients, excluding patients with any evidence of peripheral vascular disease, any evidence of coronary disease, or any concomitant procedure other than closure of PFO or MAs. That's what series has no mortality and 1 stroke. Now, here's our paper I showed you guys this morning in the first session. We had 744 patients. We had 8 deaths and 4 strokes. Are we really that much worse than the Mayo Clinic? Again, I think that data is pretty respectable. The announced mortality for consecutive patients was 0.8, and if you were less than 70, it was 0.3, and there were only 4 major strokes out of 744 patients, 0.5, but there is a stroke rate in mitral surgery, and don't think that there's not. Again, we had no exclusions. This was truly consecutive. Any age, any calcification, including reoperations. If you had a failed valvuloplasty, if you had recurrent prolapse, you're in this series. That's how you see what the numbers change between no deaths and 0.8 or 0.9 and 1 stroke versus 8 or 10 strokes. So you have to really know that. Volume does matter for the individual patient. So when you're operating on lower volume centers, it's not a surprise. Different series show it in different countries. There's a slightly increased risk. And maybe this isn't so popular looking at the program, how many people are talking about minimally invasive surgery, but I challenge everyone here that does minimally invasive surgery, not Hugo, not Neil, not the guys that do hundreds and thousands of these, but the real data in the real world shows that there's an increased risk of stroke from the side. Now, it's because of volume and experience, adding that complexity to the complexity of valve repair. But no one can tell me, looking at the literature, that the stroke rate doesn't increase from the side. Again, probably related to volume and experience, but it adds another layer of complexity for patients. That's what they care about. Do we know a repair is going to be assured? Well, here's New York State. There's some pretty experienced surgeons in New York that do mitral valve repair. That's what happens to the New York State population in the last state report. We have mandatory reporting. It's prospective and mandatory. All cases have to be reported and every institution is audited by the state. And 55% repair, 45% replacement. We're far away from what we talked about this morning, 99%, when you start talking about should every 78-year-old have asymptomatic valve surgery. And more importantly, or just as importantly, getting to a point that's been made already, that was the distribution of the top 10 volume centers for mitral surgery in New York State. That's the scatter plot we were talking about last night at dinner. Cardiac surgery is a scatter plot. You don't die anymore. That's not the question to ask. Mortality becomes less interesting than these sorts of things. That's the repair rate across 10 centers in a prospective mandatory reported place in New York 2 years ago. So we're far from doing valve repair routinely in asymptomatic patients. And Raphael showed this slide. It's, again, just remember, it's a scatter plot. Depends a lot on where you are and who's operating on you as to what you're going to get. And we have to really be thinking about that when we talk about setting up a randomized trial and understanding the outcomes of a randomized trial. And remember, about 40 patients in that paper by Bowling that you saw to sort of get to the 75 or 80% repair rate, at least in the United States. You guys may be quicker learners. This paper is important. It was just published from the Leipzig Heart Center, and they're looking at their individual surgeon outcomes based on experience, and experience based on total volume of cases. Have you gone through your learning curve? And then how many you do a week. And there's 6 or 8. You could talk 10 minutes about this paper, but I just pulled one slide up to show you this one. And what you see is, if you go to 1 to 50, the line that's sort of straight across the middle, if you haven't done but 50 cases, it doesn't matter how many you've done over per week, because you're still on your learning curve. You're still making mistakes, so your curve is flat. But what's really important is that light gray one. And this one, the very bottom one with the square, sorry I don't have a pointer. If you look at even the most experienced centers, or the most experienced surgeons at Leipzig by volume, they needed to do at least 1 or 2 cases per week, or they started looking like people that had done less than 50. 2 per week actually was the right number. That's 100. 1 per week is 50. In the US, there are 25 surgeons that do 50 mitral valve repairs a year. We have to change if we're going to really elevate the care for asymptomatic patients. The last thing was about durability. Valve repairs fail. I wonder if the young people here know the #1 reason that they fail. Inadequate repair and technical failure. That's the #1 reason patients come back for surgery. We know that from our series. We know that from the Mayo series. This was the Mayo series. Technical, 42%. So again, it's not an assumption that everybody's going to get this master repair like we saw this morning everywhere you go when you start doing randomized trials. Trying to find 45 centers in the United States to randomize patients in would be very challenging. When you look at the real world, you can see that again. What you have to do is read the title and make sure it's about something different than outcomes. Like here's something talking about our port access approach, and we learned it in 30 cases, and now we do it routinely, and it's fantastic. And then when you look at the bottom line, it's not even brought up barely. Here's the residual MR grades between port access and median sternotomy, 18% grade 3 or 4 in port access and 9% median sternotomy. Sort of somehow the reviewers missed that. This is pretty inadequate surgery in both arms. This is one of the largest series and one of the largest groups in the western part of the United States doing surgery, talking about their robotic learning curve. Well, again, their post-discharge transthoracic echo had 11% grade 3 or 4 mitral regurgitation, 1 in 10. That is the real world. These are big centers doing high volumes with robots. This is not like a place that does 3 a year. So again, we as surgeons have to really raise our game a lot to start talking about 78-year-olds playing golf with normal ventricles. And valve repairs fail. This is our data from that same series. Again, it's pretty good. If you look at recurrent greater than 3+ MR, 4% of patients get it at 7 years, but that's real. So there is this tiny little bit of recurrence of severe MR. And Tyrone's paper this year or last year in Circulation says the same thing. Can't look at freedom from reoperation. That's meaningless. That's a distraction. It's really freedom from development of moderate or severe MR again, and it will happen over time, even in very experienced centers. So I think we have to keep that sort of in mind as we start talking about what's really a successful repair. This much we do know. This is from a paper that Raphael actually wrote with Volkmar Falk a few years ago, and that is targeted referral. If you're young, you're asymptomatic, you have complex pathology, then we need to start saying those patients, particularly if they're asymptomatic, have to go to people that really are interested in gaining experience and volume and being transparent about their outcomes in mitral valve surgery. This much we do know. This is my last point. A successful mitral operation in an asymptomatic patient with degenerative MR should be defined as freedom from death, stroke, unanticipated replacement, and recurrent moderate or severe MR at 30 days and 1 year. That would be my definition for any trial. Thank you very much.
David, thank you very much. Can we hold the questions for later, please? It's me.
So I'd like to introduce Professor Simon Ray. I started doing mitral valve repair surgery when I was appointed in 1998, and a few years after that, I was working very closely with Simon. His office is next door to mine. We had a few people with recurrent regurgitation, and Simon said to me, audit your results and find out what you're doing wrong. So I tried to audit my results, and it became very clear that there's no standard which was set against which to audit your results. So I sat down with Simon, and we tried to work that through, and we produced a sort of consensus statement of what we felt was an expert statement on that. So anyway, a few years ago when I first met David, he may or may not remember this conversation, he told me he very much liked that paper, and I was really, really chuffed about that. But he said what he particularly liked about it is it didn't come from a group of experts, recognised experts. He said, in fact, nobody's ever heard of you guys. He said, you're a bunch of nobodies. So I quite like that too. But it does mean I could introduce Simon Ray as a fellow nobody. So Simon.
Perfect. Thank you. So I am clearly a cardiologist, and I may have the answer. I may not. So I'm not going to go over the guidelines in detail at the moment. You've heard a lot of this. All I want to point out, and it's very obvious to any of you who are involved in this area, is looking at the level. This is the current European Society of Cardiology, European Association of Cardiothoracic Surgery guidelines 2 years ago. And all of that evidence on the right-hand side, there is one level of evidence B, large non-randomized study. The rest of it is evidence C. And that's basically the equivalent of locking the door, not letting us out for lunch until we decide what the best form of treatment for these individuals are. So this is pretty much circumstantial data which we're basing important decisions on. And I've tried to summarize this in terms of the lack of meaningful evidence, such that the key points, and all these have already been brought out already, particularly by Raphael, but observational studies which are set up primarily to follow surgical patients don't necessarily mean that those who are not offered surgery early get adequate follow-up. And I think you can certainly direct that criticism at studies coming out of the Mayo Clinic, and I think the MIDA trial as well. It is clear that surgical results in reference centres are not reproduced more widely. Again, we've heard that a number of times already this morning. And I think it's also fair to say that assiduous watchful waiting that you might have if you're being looked after in Vienna is not what you're going to get in a large number of centres both in the UK and elsewhere. So the evidence that we have is not necessarily applicable to everyday practice in the UK. So, and I will go through this briefly because I think the most important thing that will come out of this is discussion and questions. What we are proposing to do is within the UK is to look at a trial which is essentially going to be the hypothesis of that, is that mitral valve repair within 2 months of evaluation, and you can argue at what point the clock starts on that, is superior to watchful waiting in the management of asymptomatic, severe, primary mitral regurgitation. And I want to emphasize from the start that in my very strong belief, the only way to do this is to make this a pragmatic trial of 2 clinical strategies. You cannot hone down too closely on age or etiology or anything else. This has to be a trial of treatment strategy, not narrow groups of patients, because there are lots of trials like that in the literature which turn out to be fantastically difficult to do and ultimately meaningless because the results don't apply to the majority of patients we see. Entry criteria, we tried to keep this as simple as possible. Basically, severe primary mitral regurgitation without a current class 1 or 2A indication from the European guidelines, and it's open to debate, I think, as to whether that is an end systolic diameter of 4.5 or 4. I would prefer 4. Amenable to valve repair with a high chance of success, low mortality, applicable to the unit that is enrolling the patient. And I think probably the most important thing about this is that all these decisions will be made locally by the heart team in the institution which is taking part in the trial. So that's where treatment decisions will be made. So we sent out an email to all surgical centres through Ben and Steve Livesley about a year ago, and we got a number of expressions of interest. Many of you in the room may have been part of those expressions of interest. We had about 20 centres so far in principle interested in taking part. The principal criteria in terms of surgical access into the trial is that we have a surgical subcommittee headed by Brendan Bridgewater and Steve Livesley, who will look at surgical centres that want to take part on the basis of existing experience and outcomes in mitral valve repair. So we are wanting experienced centres to take part in this trial. And we are also expecting those centres to have a cardiologist, at least one, who is dedicated to following up these patients in respect of the trial, and also ideally in respect of the generality of practice of valve disease. We're going to randomise patients 1-to-1. We expect surgery within 2 months, and subsequent follow-up will be according to current guidelines. So this is a guideline-driven trial. The primary endpoint is a composite of cardiovascular mortality and hospitalisation for non-fatal cardiovascular events. I'm sorry, I've missed stroke off here because it's important. There's quite a bit of focus in atrial fibrillation in these endpoints, and that's because I absolutely buy the data that you've seen already, that atrial fibrillation is a bad thing if you have mitral regurgitation. And one of the roles of optimal management is to stop patients going into atrial fibrillation, at least permanently. There are a number of secondary endpoints which we're going to include, and it will be the subject of pre-specified analyses. These are the individual components of the primary endpoint: total mortality, functional capacity at 3 years, and I'll explain the time frame in a moment, and some quality of life measures, and echo and CMR parameters of left ventricular function, which will be core lab adjudicated, and I think that is another very important issue. All the echoes and the CMR, which determine entry into this trial and the follow-up, will be looked at in central laboratories and analysed there. So how do we decide how big a trial like this is? And you know, I know some of you in the audience will have been part of attempts previously to set up similar trials. And the bottom line is it is extremely difficult because, as you've already heard, the available evidence in the literature is highly variable depending on the approach taken. There are no randomised trials to base this on. And 5-year events in medically treated patients vary from about 33 to 43%. So we've plumped with the average, which was highlighted in the Bono paper that was shown earlier, of about 40% at 5 years. And we've assumed a relatively conservative, in my view, reduction in risk in early surgery of 37.5%. And you can see why we've done that, because it neatly fits into 5-year event-free survival rates of 60 and 75% respectively. I don't pretend to understand the statistics, but the statisticians at the trials unit tell me that in order to demonstrate a conventional significant difference, we need 96 events, and on the assumption of the event rates that we pre-specified, that will require 300 patients. If we allow for a bit of dropout, we get 326. Assuming 20 centres, we think we can do this, but it will need 20, or at the very least 16 centres. Staggered initiation of centres, and that will require each centre to recruit between 6 and 7 patients a year. And that will give us our population of 325 patients, with longest follow-up of 6.5 years, shortest follow-up of about 3.5 years on all these patients. And again, that's something perhaps we could discuss. We're going to do some sub-studies, and I think probably one of the most important of this is going to be cardiac MR, and this is data kindly provided to me by Saul Meyerson in Oxford, who's got some very interesting data on the use of MR to predict those patients who are going to develop surgical indications over a period of time. And it may well be that one of the important spin-offs from a trial like this is that we do develop much better ways of predicting patients who will benefit from surgery. We'll also be looking at biomarkers and health economics. There is another trial which is very similar, and some of you may be aware of this, and this is being conducted in Holland by a group calling themselves the Dutch AMR Trial Consortium, and we have been in close contact with this group for around about 1.5 years now. Ben and I and our statisticians and trial managers have met with them on a couple of occasions, and they are struggling. They have slightly different power calculations to us. They've assumed a rather more beneficial effect of early surgery, but they're going to recruit 250 patients. But at the moment, they are struggling to get centres to take part in the Netherlands because of the peculiarities of the way that the health service is set up. But we have harmonised the important elements of the two protocols such that we can perform a joint analysis of these two protocols. We can join the numbers of patients together, and that will provide us with a safety net if we cannot recruit in the UK. I'm optimistic that we can, but it does provide us with some sort of a safety net. So where are we up to? We sent an initial in-principle application into the BHF last September. That was approved, and we're now in the advanced stages of putting together a full funding application for around about 2.1, 2.2 million for a standalone UK trial. This will be run through the Manchester Clinical Trials Unit. The reason I put the proposed steering committee is I want to highlight the names on the right-hand side of this slide as I look at it. So Referral, Rosenhek, Linda Gilliam, and Stephen Charmelot from Utrecht in Belgium, in Holland, apologies, have been extremely helpful in advising on the content and the nature of this trial. And I think it is very important that we have some externality. Stephen Charmelot is the principal investigator of the Dutch AMR trial. And I'll stop there. Thank you very much.
Ben, do you want to comment, or do you want to move on to your something else?
Yeah, I think those have been an outstanding series of talks, actually, and I think I've learned a fair bit. I was going to sort of represent the case and see if anybody's changed their mind. Has anybody heard things today which would influence their decision to take that fit guy on for surgery who is asymptomatic? His left ventricular and systolic dimension is 3.5 now, just for want of any discussion. Anybody change their mind? Anybody who would have operated on him who would now not operate on him? Anybody who wouldn't have changed their mind either way? Anybody want to stick a hand up?
Mr. Kendall did.
Wants to ask a question. Oh, right.
Oh, I see, right. Okay.
I guess we should invite...
David.
Let's randomise him. Yeah.
Sorry, could you just tell us again about this trial? I mean, I didn't understand I want to make sure I understand the primary endpoint.
Come back. Yeah, come back.
So, This has been one of the most difficult things that we've been grappling with in terms of setting up the trial, because it is very difficult. So if you look at the literature in terms of the bad things that happen to people with mitral regurgitation, heart failure is clearly a bad thing. Death is a finite and a very bad thing. We think that atrial fibrillation is probably a pretty bad thing, and clearly stroke is another thing that may be related specifically to operation, but is also a bad thing. So in terms of trying to define how you measure the degree of badness that is attributable to either of these strategies, one of which may be better than the other, we think that a composite of those elements is the best thing to do. Clearly, it makes the power calculations a lot easier if we're not just looking at death, because the only way that we would have a true mortality trial, it would be enormous and unachievable. So we've gone for the combination of cardiovascular mortality, and I think it's a very legitimate argument as to whether that should be total mortality, which would have been my preference, plus hospitalization for heart failure, stroke, atrial fibrillation beyond 90 days to allow for the fact that clearly some of these people are going to have transient AF post-surgery, which may not matter a great deal if it's not accompanied by immediate complications. And then, as say, the individual components of those as secondary endpoints. But I would very much welcome any views on this, because it is something that we have gone back and forward with many, many times.
So what's the surgery group? What's the, I get the fact you're going to get randomized to medical therapy, and then you watch for AF and heart failure, and you have a stroke or you get admitted to the hospital. But what if you have surgery? What's the success of surgery defined as?
So in exactly the same terms. So the avoidance of any of the bad things, essentially. So what we're aiming to do is at the end point of the trial, so between 3.5 and 6 years, depending on rate of recruitment, is to compare those endpoints very simply between the two groups, such that if you have an early operation, are you free of those endpoints, which you may have if you don't have an operation and you continue on medical treatment.
But what about recurrence of MR? This was the problem in the ischemic trial, which just has everybody up in arms in the U.S. You did a randomized trial, and they picked 12 centers, and they had a 30% residual MR grade that most expert centers don't see, and then patients didn't do well. So this is really, to me, very important.
So you're absolutely right, and that is at the moment a secondary endpoint. Because one of the difficulties is you could have that as a primary endpoint. So then, do you have that? Is it a matter of the extent of residual regurgitation post-repair, the timing? What we've gone for is the consequence of that in terms of does it make you symptomatic? Does it cause you heart failure? Does it put you into AF? Does it give you a stroke? But I entirely accept your point. But at the moment, it's a secondary endpoint.
Can I just throw something in here as well? You're in danger of comparing an operation with no operation versus an appropriately well done perfect repair and the outcome, which is what you really want to know. Because a properly done repair, removing MR with a well-functioning valve, is what you're really testing. And the trouble with, and I guess one of the problems you're going to have in recruiting is getting that quality across the board uniformly and reproducibly.
Can I make a comment on that? So one of the reasons for presenting this here is because this is exactly the sort of discussion that we want to have, and this is not easy. What we don't want to do, I think, in this trial is compare a mitral valve repair early surgery strategy by Frank or David with a watchful waiting thing, because it has to be cascadable. But I think we do need to do all due diligence to make sure that the surgical strategy is done to a sufficiently good level. And what we were thinking, and I'd be very happy to be criticised on this, is that we go through some process to say, if you are going to be in the trial, you need to be doing more than a certain number. If you're in the trial, you don't just need to have a organisational volume, you need to have a clearly defined subspecialisation policy within your hospital, so the individuals are doing it to a reasonable volume. We will look at your most recent data to check that your repair rates for degenerative disease are higher than X and Y, and maybe do some questionnaire around that. So we try and assure the quality of the people who are put into the trials. What we will also find out, having gone through that process from the follow-up echoes and stuff, is if actually we find the residual or recurrent regurgitation levels are higher than we expect, we'll have some interesting findings out of the back of that, even if it's not what we set out to find. So that's kind of what we were thinking. But like I say, we're really keen to get the big brains around thinking and commenting on that.
Can I just throw it back in again? One of the reasons I hung back was just this. What you want to be careful about is if you're just comparing the current state of referral and acceptance and doing a mitral valve repair in what we've all agreed is a totally unsatisfactory setup in this country, keep it to ourselves for the moment, versus what ought to be a well-carried-out optimal treatment versus a watch and wait. And I'm really worried that you might get the response that actually mitral valve surgery should not be happening, not because it's a bad thing to do, but because where it's being done and who it's being done by is a bad thing to do.
But we will know that, Frank. That's what I would say. We will generate some of that learning from the way we plan to follow these patients up. So,
Ben, Simon, I just think about some of it. The one comment was what you've just discussed, and this seems, I've got a couple of concerns. It's very laudable. It's an important question. One is, this isn't really a real-world trial. You're talking about comparing surgery by experts with medical follow-up that is not the medical follow-up you get in the UK normally. So both of those are unreal, not real-world situations. The second, which is greater concern to me, is even if you took an end-systolic diameter of 40, we've seen today that once you get above 40, your survival is impaired. Now, that message to me is you have to operate before the end-systolic diameter is not 40, not when it gets to 40. So I would have a real problem waiting for the patients and enrolling them in this trial with an end-systolic diameter of 45. I think that would be a big issue.
But you don't need to do that. So, well, let me take the first question first. So the difficulty here is, as I alluded to already, is you have to make the trial meaningful. So you could say, well, we're only going to have 2 centres in the UK that can take part. You never have a trial. You could say, well, it's open to everybody, and you absolutely have the problems that you're going to get centres with low volumes. And I think, as Ben has articulated quite nicely, you have to plump for the middle ground. And I think it is a difficult question to answer. It's a very difficult trial to run, and the fact that it's not been done elsewhere is another illustration of it. But it is still a very important question. So we have tried to make this as pragmatic a trial as we possibly can. It can be tweaked for sure. In terms of your comment about the inputs, you don't have to wait to get to 45. I mean, the decision is made by the heart team in the hospital. So if you feel that there is a clear-cut indication for somebody to have an operation in your practice, you go ahead and operate on them. It's those patients where there is equipoise. And that decision can only be made by the recruiting centre, because only the people in the recruiting centre know what they are comfortable with. The guidelines are guidelines, and you have to base a trial on something, and hence you clearly have to base it on the guidelines. But it is up to the individual recruiting centres.
David, last word, then we have to wrap up
Sure.
for the next session.
The problem is that, I mean, it's a challenging study, but it's a lot easier to teach a first-year graduating doctor how to do watchful waiting than it is to be a master mitral valve unit.
Yep.
So I think this is really problematic for me. You're going to have super optimization of medical therapy from the Hawthorne effect, and your surgery, just because you have a Hawthorne effect, isn't better. So this is heavily weighted toward the watchful waiting group doing better. The second thing is that I'll argue again that these parameters, the definitions of failure are different. And a watchful waiting patient that came to you with an ejection fraction of 72 and over 3 years has an ejection fraction of 55 is a failure. That patient's long-term, not 3-year survival, but 20-year survival has been impacted. So that should be a failure of medical therapy. Vice versa, a early operation on an asymptomatic patient that has 3+ MR a year later or had a minor stroke had a failure, not just because he didn't get readmitted to the hospital with heart failure or developed atrial fibrillation. So I think this, and I don't know how the statistics work, but I think you should go back and relook at what's the definition of success in each arm, because success is very different depending on whether you got followed medically or whether you had surgery.
And you've hit the nail on the head in terms of the difficulty of setting this up. I mean, all of those are in there as secondary endpoints. The question is whether they carry sufficient weight to be in as a part of a composite primary endpoint. That's the difficulty.
I'm sorry to cut it short there. Thank you very much. The debate could go on all afternoon, and maybe we can pick it up outside, but we need the lunchbox sections to start. So thank you to all the speakers, and great debate. Well done.